A very good evening to all of the respected speakers, the moderator, and the president, sir, and the panelists. We will be proceeding with the Eizoc ARC webinar. Today's topic would be the evaluation of proptosis. So I request Mr. President, sir, Mr. President-elect,
President-elect, yeah,
President-elect, sir, Sir Zenta Barua, to kindly give the welcome address.
Good evening, everybody. I welcome everybody to this ARC webinar on evaluation of proptosis. Proptosis is quite a common feature here, and it is just protrusion of the eyeball. And the term exophthalmos we reserve it usually for disease-related proptosis related to thyroid pathology. So today, this could be due to intraorbital causes or causes from surrounding the orbit. And there are a lot of issues in this, and we should, right from clinical assessment, palpation to observation, we should go it very systematically, which we are going to learn today. I welcome Dr. Gyan Bhaskar, and I hand it over to the moderator. Thank you.
So you are muted, Dr. Matty.
Sorry, sir.
Yeah.
Sir, I'll be introducing our respected moderator, sir. Our moderator, sir, let me introduce our moderator, Dr. Jayanta Kumar Das. He is presently he's the unit head of the Department of Ophthalmology at the Apollo Hospital, Guwahati. He is also the senior consultant orbit and oculoplasty and cataract and neuro-ophthalmology services at the Retina Center Hospital, Guwahati. Dr. J.K. Das has done his DNB and PhD in ophthalmology. He has 2 book chapters in his credit and 18 international publications and 23 national publications to his credit. Dr. J.K. Das needs no introduction in terms of in his activities in the different professional groups. He is currently the Joint Secretary of the Ocular Trauma Society of India, and he is the General Secretary of the Ophthalmological Society of Assam and Member Managing Committee of the AIOS. He is also the webmaster of Eizoc, and is the executive member of the Oculoplastic Society of South Asia, and formerly council member of the Asia Pacific Society of Oculoplastic and Reconstructive Surgery. He was also formerly treasurer and assistant general secretary of the treasurer of the Oculoplastic Society of India, and formerly the assistant general secretary, treasurer of the Ophthalmological Society of Assam. Dr. J.K. Das has multiple awards to his credit, including the prestigious E.T. Selvam Award in 2006. He is also won the International Hero Awards in 2021, the Best Video Award in the World Congress of Ocular Trauma in 2019, the Best Paper Award Orbit at the Annual Conference of the Midterm Oculoplastic Society of Association of India 2021, Best Paper Award at Annual Meet of the Midterm Oculoplastic Society of India Conference in 2019, Best Video Award in the Trauma Society of India 2023, Best Video Award at the Eastern India Journal Ophthalmological Congress in 2007 and 19, Eizoc State Felicitation Award in 2023, the Best Paper in External Diseases at the Annual Meeting of the OSA in 2005, 6, and 7, Best Video Award at the Ophthalmological Society of Assam in 2006, 17, and 18, and Academic Achievement Award at the OSA 2008. So I hand over the proceedings to you, Jayanta Da.
Dr. Jayanta, you have to unmute yourself. Unmute, Dr.
Kindly
Jayanta.
unmute, sir.
Yes, sir. Yes, sir. Dr. Chanchi, thank you for your kind introduction. And just I want to introduce our today's star, Gyan. He is no need to actually introduce too much. He is one of the youngest professor in a government setup in a prestigious RIIGIMS Patna. So lots of award, and he is also unit head in one of his unit 2, and he is a very active member of our society, Eizoc as well, oculoplasty and all in AIS. So with us, Dr. Aparna, our Aparna Dubedi from Mumbai, one of the very, very famous surgeon, and then the very active member of Oculoplastic Association of India as well as in all other societies. So we are very lucky with the blessings of our almighty President sirs and that Jayanta Bura sir, all are here. So lots of PGs are here now. So today Dr. Gyan will discuss with some important topic which is not discussed in earlier era in the colleges, because the lack of the CT scan MRI, it was thought it was a very, very tough, and most of the cases that ophthalmologists refer to the neurosurgeon, plastic surgeons, and the others. Now, within a last 3 decades, there is a tremendous sense in that oculoplasty, and on that part, and I just thank our ARC team to include in oculoplasty in our discussion. Now I invite our speaker, Dr. Professor Gyan Bhaskar, to say what about that the new things and what are the evaluations in proptosis. I just request Dr. Professor Bhaskar to start.
Dr. Jayanto, we also have Dr. Rajesh Manjunath Chaudhary as a panelist from West Bengal, Calcutta.
Yes.
Welcome, Dr. Rajesh. I just saw him.
Yes, Dr. Rajesh. Yes, yeah. Dr. Rajesh is one of our, yes, Rajesh Manjunath Chaudhary. He is one of that our today's star, and he is also lots experience in lots of the our hospitals, even including the international hospitals.
And before Dr. Gyan starts his talk, just one information and invitation that we are going to have the Eizoc annual conference in Kalimpong. That will be on 29th, 30th December and 1st of January. So everybody who is listening to today's talks and all, participating in the webinar, do log into the Eizoc website for registration. The registration will open next month. Over to you, Gyan. Dr. Gyan.
Yes. Yes.
Thank you so much, sir. Thank you. My slide is visible, sir?
Yeah.
Yes.
Your slide is visible, Dr. Gyan, but you should be writing Professor Gyan. I think you are professor now.
Yes.
Thank you. क्या हुआ? Good evening, everyone. हाँ, move कर रहा हूँ.
Yes. Moving.
It's moving, sir.
Good evening, everyone. First of all, I thanks to Eizoc whole team and especially ARC chairman, Dr. Professor YC Mathi sir, and President sir, Dr. Pranav sir, and President-elect Dr. Jayanta Barwa sir, Secretary Dr. Bhardwaj Swaraj Bhattacharya sir, and Chairman Scientific Committee Dr. Sabasati sir, and all the panelists and moderator, along with senior colleagues and dear PG who has joined today's for this session. Generally, proptosis are the we commonly encounter in our day-to-day practice, but sometimes where the PG student or our general ophthalmologist see the proptosis or bulging the eyeball, directly refer to the higher center or any other doctor for further management and evaluation. But today's I am going to only basic thing, that's if we see the case of any bulging or any proptosis or swelling over the eyelid, at least we do the basic workup so that we should make a proper diagnosis and proper referral to the patient. everyone is know how proptosis is defined as the only displacement of the globe by more than 20 millimeter from the lateral rim, or we can say there is a more than 2 millimeter difference between the apex of the cornea of the two sides. Just you see here the diagrammatic representation with the that's the lateral orbital rim and the apex of the cornea, and if there is a distance between the lateral orbital rim and the apex of the cornea is increases, then we can say it could be the proptosis or the bulging of the eyeball. Generally, in our day-to-day practice, we see such type of cases like there is the only mild bulging of the right eye of this female, or there is the there is a bulging of the both eyelids, along with there is a retraction of the lid, and also there is a proptosis with the deviation inferior superior area, or this female is of the proptosis with there is a conjunctival chemosis, and there is a corneal keratinization or corneal exposure keratopathy. And some cases in the young child, always we see such types of cases like bilateral proptosis, conjunctival chemosis, and sometimes there is a lid swelling along with the exposure keratopathy and lid edema, conjunctival edema, chemosis. And sometimes we see the such type of cases like a swelling, pain, and intense bulging of the eyeball. So there is the why we think or why should we go for the evaluation of such type of cases, or what should be our aim, and how we'll proceed for the evaluation. Such type of the question is always in our mind. What is the aim? So basically, we how to proceed for the evaluation. Every disease or the eye, either ocular disease or any disease, it should be on the proper history, followed by the proper clinical examination, supported by the investigation. On these basis, we can make a differential diagnosis and final diagnosis. So before going to the evaluation of the process, we should know the normal anatomy of the orbit. Basically, orbit is our quadrangular truncated pyramidal shape, and it is bounded by superiorly anterior cranial fossa, medially by the nasal cavity and ethmoidal air sinuses. Inferiorly, there is a maxillary sinus, and laterally the middle cranial fossa and temporal fossa. And these are the most important 7 bone which create the boundary of the orbit, and these are the volume of the our socket. Generally, if there is the volume increases, then the globe is proposed outward or inward or any direction. And these are the some potential spaces in relation to the orbit where there is any lesion in these or these spaces, and we can diagnose according to the presence of the lesion, either it is supra-periosteal lesion or extracorneal compartment or intracorneal compartment or subtenon or supraquadal compartment. According to this, there is the movement of the eyelid or proptosis of eyelid as axial, temporal, lateral, or superomedial or inferomedial. Most important part when we're going to the evaluation part, most important is the history taking. If the patient is came to with us with the proptosis of the eyeball or any bulging of the eyeball, it should be always history should be taken age of onset and duration, either short-term duration, long-term duration, or it is progressing or not, or the proptosis or bulging of the eye is either constant or intermittent, or it is variable with the posture or any strain. And always ask about the vision. Either it is preceded by the loss of vision, a diminution of vision, or followed by the diminution of vision after the symptoms, or it is either it is stationary or progressive, or any associated with, if there is a patient is complaining that there is a diminution of vision, either it is associated with the field defect or not, or any history, always to take any history of sinusitis or any dacryocystitis, dental infection, or previously treated dental infection or any dacryocystitis or any nasal infection should be ruled out, and always take the history regarding that. And always ask the patient with the if patient, bulging or proptosis, either with pain or any double vision or diplopia, any systemic association like fever or systemic complaint like irritable bowel syndrome, or any other lesion like mass lesion in the other part of the area, or any previous history of the cancer treated earlier. We should always take the history, and patient is on any thyroid disease, diabetes, hypertension, or HIV or syphilis should be ruled out, or any post previously ocular injury, trauma, or any previous ocular surgery always should be ruled out, or the patient is on either any medication or family history or any active or passive smoking. These are the history should also take with the patient. And regarding the examination of the proptosis, don't jump to the any direct tunnel vision like slit type examination or torchlight examination. Always inspect the patient, not only limited to the eye. Also inspect the patient. If the patient is coming in our OPD, always general examination or general appearance of the patient should be noted. Either patient is cachexia build or any thin or any gait changes or any there is appearance of the skull is abnormal, there is any swelling in the neck area, or proptosis either unilateral or bilateral. And there is a 6 P. We should always think and always should be examined primarily like this: pain, progression, proptosis, pulsation, palpation, and periorbital changes. These are the cardinal 6 points. Never miss this thing to examine when we are examining the patient of the bulging the eyeball or the proptosis. Regarding the pain should be either it is due to any just see the patient is presented with us with the RTA. The patient is having the periorbital swelling with intense pain, and there is a fracture and periorbital hematoma. Or any infective lesion. This female is also having the there is a long history, 6 to 7 year history, but patient is having severe pain and due to the exposure neuropathy. And if patient is also presented with us with the orbital cellulitis, the infective lesion, orbital hemorrhage, any malignant carcinoma, if patient is presented with this pain. So pain may be of the other causes and always should be noted. And second is the progression. If any lesion is abruptly progress within an hour, it should be due to the bleeding of the lymphangioma or any orbital emphysema, fracture or post-traumatic fracture of orbital wall, or retrovalvular hemorrhage, or sudden rupture dermoid, and rupture of the ethmoidal mucosal. If the patient is having there is a swelling and patient notice that there is a sudden swelling of the eyeball, it should be kept in mind. And if the progression is occurring over a day or week, it should be the keep in mind always that it could be the idiopathic inflammatory disease or any orbital cellulitis if there is associated pain, or thromboembolitis. Sometimes in the younger child, if the patient is presented with the bulging with the pain in the case of the rhabdomyosarcoma, sometimes we can have a progression in the thyroid ophthalmopathy, neuroblastoma cases, and sometimes in the metastatic tumor, progression can occur within a week. Or if there is a progression over a month to the year, it could be the dermoid or benign tumor or neurogenic tumor, any cavernous hemangioma, lymphoma, and fibrous histiocytoma. These are the common thing in which there is a disease or proptosis. This just to see the patient is having the 6 year of from the 6th year there is a slow progression of disease. Patient came to us only when there is pain and redness, it is either due to the exposure keratopathy or any lesion of the pain. And when we did the investigation, patient having the any vascular malformation. So always think these are the things we can keep in mind. If the process is intermittent, often come and when then we should orbital varices, sometimes hemangioma or carotid cavernous fistula should be kept in mind. And if we are dealing with the proptosis for the evaluation, then always should rule out either it is true proptosis or pseudoproptosis. Always think or always examine the face or any facial abnormality or any ptosis of the other eye or enucleate eye, any prosthetic eye should be kept in mind, and always should rule out to pseudoproptosis. Then we go for the evaluation or inspection or any investigation for the disease of the proptosis. Generally, when do the inspection, then always examine for the unilateral, either it is unilateral or bilateral, or either proptosis is axial or non-axial, or it is lateral, inferiolateral, or superiorly. Just we can see in these cases, there the proptosis of the right eye, it is bulging the eyeball inferior-temporal. This is the axial one, and third one is the bilateral axial proptosis. Regarding the examination itself, a proptosis, only we can examine in our OPD the quick method to rule out any bulging. We can go for the necessary test or the bird eye view test or worm hole view test. Just ask the patient to sit in front of the examiner and looks in from the head, and we see the eyebrow, and if there is the bulging the lid or the cornea or upper eyeball is visible above the eyebrow, then we can think there may be the proptosis bulging of the eyeball. Then the simple ruler, the plastic ruler, we can go for the examination. It keep in the lateral aviator rim, from the lateral aviator rim and effects of the cornea, and we can measure from the temporal side. It is within normal range, or it is it is or abnormal range. We can compare with the other eye, normal eye, or we if there is a bilateral, then we will compare with the normal value of the proptosis. And another quantitative assessment of the process by proptosis by the exophthalmometer. There are so many exophthalmometer. Generally, we use in our day-to-day practice the Halter or exophthalmometer or Nogals or Mortis. These are the exophthalmometer by which we can assess the quantitative measurement of the proptosis of the eyeball. This is the Lude's exophthalmometer. This is the transparent plastic ruler in measure in millimeter. This is the thicker than the normal ruler. There is a groove made in apex of the ruler, and it fit at the lateral orbital rim. And beauty of this ruler is there's a marking from the apex, so that it is easier to measure from the lateral orbital rim to the apex of the cornea, and it is better than the hurdle if there is a facial asymmetry. And it is also transparent, and we can directly visualize the amount of the proptosis. And there is the Hartel exophthalmometer. There is a two pre's made, and we can also measure. But in this condition, we have to also measure the bilateral lateral orbital rim along with the proptosis of the eyeball. But demerit of this thing is, if the patient is not able to fix it centrally, or if there is a deviation, then it is very difficult to measure in such type cases, or if the patient is not cooperative, or not, the patient is unable to fix it on this primary position. These are the steps for the PGs. We are going to do the Hartle acceptor per meter. Initially, it is sometimes difficult to visualize the lines mounted in the prism. There are two lines, anterior and posterior prism, and sometimes very difficult. But when the, 1 to 2 cases, if we practice, then we can visualize the line, and then we can measure the amount of the proptosis. These are the grading, mild, moderate, or severe. If there is a mild one, is the if there is a 21 to 30 23 millimeter, or moderate is a 24 to 27 millimeter. If the severe proptosis is 28 and more than that, we can grade according to the measurement of the. And these are the Nogal's ophthalmometer. This can be used if there is due to the trauma, and there is any cases of traumatic, there is the loss of orbital rim. This is the beauty of this ophthalmometer, is it measure the frontal bone and maxillary bone. Reference is taken the frontal and maxillary bone, and according to that we can measure the amount of the proptosis. These are the comparative compare between the all except for Milder, Haltel, Ludis, Nogals, and Mortis, and these are the advantage and disadvantage of this technique for the measurement of amount of the proptosis. And again, we can go for the measurement of ptosis by CTA scale, just measuring the anterior corneal surface to the interzygomatic line and distance for the posterior margin to the interzygomatic line. We can also measure the amount of proptosis with the help of the CTA scale. Fourth one is the when we are examining, we should not miss to examine the pulsation of the any mass, and pulsation can occur in the lesion, the keratocavernous fistula, or any aneurysm of the ophthalmic artery, or if there is a congenital meningocele or meningoencephalocele, or any traumatic or operative hiatus, then we can have a pulsation. And we should also auscultate on the closed eye by the back of the stethoscope, and we also hear the bruits. These are the lesions in which we can pulsate or hear the on auscultation. Without bruits, we have the neurofibromatosis or meningoencephalocele, and any surgical removal of the orbital fold. But if there is the bruits is present, then always suspect for the carotid cavernous fistula or any dural arteriovenous fistula or vital arteriovenous fistula. So always pulsate if there is the auscultate if there is the proptosis of the eyeball. And then the palpation. Palpation is the most important part. Always look for there is temperature or tenderness, or always a margin of the orbital margin. Always to feel the orbital margin intact, or any gap between the orbital margin, or any retropulsation of the globe. Just press with the thumb or a finger the globe. If there is the if there is a retropulsation, if there is a mass, then globe is not go into the orbit. But if there is no mass, but the eye looks like bulging, but it will reduce. Eyeball is reduced. But if there is a mass, then there is the resistance. Feel the resistance to on the retropulsation. Always examine the lymph nodes. First, sentinel's lymph nodes, we always think about the drainage of the lymphatics and periauricular lymph node, cervical lymph node, postauricular lymph node, axillary lymph node should always be checked. And if we note the there is a mass, then position should be noted. Where is the position of the mass? What are the size and what are the surface? If mass is attached or it is movable, If consistently the hard, firm, or rubbery, spongy, or soft, it gives the clue of the diagnosis, and it is compressive or reducibility should also be checked when doing the palpation. And always examine the orbital rim. If there is a deficiency or a defective in the orbital rim, it could be the malignant lesion or any trauma. So orbital rims should always be palpated. Retropulsation already discussed. If there is a mass lesion, and then we feel the resistance when encounter the presence of the solid mass in the post auricular in the below the orbital or any compartment lesion, either intraconal or extraconal. Then lymph nodes always should be examined, and periorbital changes. Always look for the periorbital changes. Sometimes in the neurofibromatosis cases, with S-shaped lead can be occur, or any cul-de-sac lymphoma, we can see the salmon color mass, or in thyroid eye disease, there is the lead retraction or lead lag should be noted. And also check for the ecchymosis or lead mycosis, fungoids, lead, or any lower lead edematous swelling of sometimes we can see in the cases of meningioma, or a prominent temple spondyloid wing as meningioma. We can also see all these cases other than the ocular examination. Always see the periorbital changes. And always do the proper sleep time examination from lid to the fundus. Lid, see the condition of the eyelashes, lid margins, any congestion or conjunctiva, there is congestion or dilated blood vessels. Sometimes we think there is a dilated blood vessels with the proboscis. Always think there could be any vascular lesion, and any cornea, there is to rule out any SPK or exposure keratopathy. Then if there is a cystic lesion, trans-illumination should be done, and each and every patient should be examined for the visual acuity. If there is a reduced visual acuity, should always find out what are the causes of the reduce of the visual acuity. Either it is due to the exposure keratopathy, corneal lesion, or any compressive lesion, or any refractive error. Pupillary reaction always to note if there is no corneal exposure keratopathy or cornea, if cornea is not hazy, then we look for the pupillary examination. If there is any RAPD to present, then always think there should be compressive optic neuropathy or any optic nerve pathway disease. And the ocular motility, always check the all quadrant ocular movement should be checked, or any restriction of the ocular movement. If there is restriction, we can do the post-duction test. Either it is due to the restrictive ocular motility, or it is due to neurological restricted ocular neurological causes, or any compressive or mass lesion. And then post-duction test should be done further. And then intraocular pressure should be ruled out if the cornea is not compromised. Particularly in the cases of thyroid disease, always check for the intraocular pressure. There is a risk of the IOP, or there is a glaucoma for thyroid ophthalmopathy. Proper fundus examination should be done. If any case of the proboscis, should also do the always do the fundus examination to rule out any mass lesion, the compressive lesion, either fullness of disc, or any choroidal folds, or any retinal folds. And then systemic examination also should be ruled out if cases of neurofibromatosis, then a CAP or spots were also noted, skin pigmentation, feature of hyperthyroidism, any hemangioma elsewhere in the body, and a scalp, any bony lesion, or organomegaly, or any always systemic examination, palpation of the whole abdomen should be done to rule out any mass lesion. And always do the clinical examination like escalation of the chest, or chest whole abdomen ultrasound should be done, and chest X-ray to rule out any secondaries to the or any otolaryngological examination, paranasal sinuses or nasopharyngeal mass should be ruled out. And nervous examination always rule out sometimes proptosis or anyptosis. There is the third, fourth, seventh, sixth, seventh nerve palsy may occur. So these nerves should be checked. And investigation, or if we after the proper examination, we can go for the routine blood examination. And always, if there is a younger patient or if there is the bilateral proptosis, then always go for the CBC with peripheral blood smear to rule out any blood disorders or leukemia. Ultrasonography should be done the whole abdomen and locally we can also, this is a non-invasive technique, and initially we can also at least we can assess the mass lesion, and with the color Doppler supplement we can assess either it is the vascular lesion or any mass lesion. But drawback is it did not give the confirmatory or localization of the lesion or exact the localization or exact nature of the lesion. And CT or CT MRI should be done if to rule out any condition of the bony lesion, nature of the mass, or extent of the lesion. If we suspect there is the vascular lesion of say a soft tissue mass, then we can go for the MRI of the orbit or paranasal sinuses or brain. Then venography or arteriography should be done, and CT or MRI angiography, if required, we can do. And lastly, if it is not confirmed on the base, not confirmed by the radiologically, then if mass is then we can confirm by the FNSA or incisional biopsy. If the mass is localized, well defined, then we can go for the excisional biopsy. And sometimes core biopsy lesion can be confirmed by and managed accordingly. Thank you so much, sir. Thank you, sir. If any question, then we can discuss.
Thank you. Thank you, Dr. Gyan Bhaskar. This was a wonderful, very elaborate, very conceptualized, and very good for the postgraduates and residents. A lot of information was there, and Professor Matty will comment on that, and then Dr. Jayanto.
Thank you so much, Dr. Gyan, Professor Gyan, for a wonderful presentation. I think I'll still hand over the proceedings to our moderator.
Dr. Singh, yes, excellent. He covered it all. So there is some points like he mentioned there's a pulsatile, sometimes pulsatile. One is pulsatile. One is that is a positional changes. These are very two important. Most of the time, our ophthalmologists may miss. One is the CCF, keratodermocavernous fistula. It may be a direct, it may be indirect. Indirect is a little easier, but sometimes that ophthalmologists may miss it and then other surgeons, neurosurgeons. But with the help of MRI, there is a sign. One is a hockey stick knife, hockey stick in sign, which is in ultrasound, we can pick it up. And if we can do a gonioscopy. In orbitotomy, most of the time we are looking for generally exophthalmometry, etc. But another point is that Hartel's exophthalmometry is better to evaluate all exophthalmos, but it is very, very costly. For the residents, most option is, or for the young ophthalmologists, for even for us also, I am doing at present the practice. So now that is a LODES is one of the very good alternative for evaluation. So that along with the LODES, and we can use another plastic ruler, because another disadvantage with that LODES is only one directional, but there is no such prism effect on that. So we can use a multiple scale along with that, and we can say it is a axial or it may be upward, downward, everything we can. I want to ask from Dr. Rajesh to highlight few points regarding the difference between the disadvantages of the loads or any plastic rollers over the this. Dr. Rajesh, please.
Thank you, Dr. Gyan. Very nice presentation. What Dr. Jointo has been asking us that the differences between the use of fluids and hurdles. Is that the question, Dr. Das?
Yeah. Of course, there is a financial is one of the part, but apart from that, there's some technical issues with this. Yeah, please.
You know, I actually, honestly speaking, my experience is totally with hurdles. I never actually used fluids in my practice. Both in UK and India, I have been using hurdles all the time. And but as you know, like the fluids exophthalmometer, as you can make out, it is actually like a transparent scale which fits along the rim of the orbit, so that you can read out where the location of the corneal apex is vis-a-vis the orbital rim. Obviously, it has got the same disadvantage as the hurdles because it relies on the orbital rim. So in case there is a trauma to the orbital rim through surgery or through any accident, you cannot use it. And at the same time, I think another problem is that it will be very good in case of axial proptosis. But in a non-axial proptosis, I don't think it will be that much relevant. In a non-axial proptosis, you can use various other mechanisms, but I personally find using two scales, two transparent rulers side by side will actually give you a good idea about where is the which direction is the globe being pushed aside by the lesion inside the orbit.
Thank you. For that students, actually, that we are basically tuned up with a single scale. But if we are using a two scale, there is a lot.
Two scale method is better.
And it should be a very clear marking. That's important in exam in hurry. We are generally with a dirty scale. So sometimes, or there is one of my technique is that I cut it up to 0. I just customize that plastic ruler at 0 level. So it will be easier. No need to minus it. That's for the students is very, very important. So some points.
Can I have a question, sir? In facial, in cases when you have facial asymmetry, what is the best method actually of measuring the thing clinically?
I personally would say that when you have a facial asymmetry and you find that one globe is looking, one eye is looking more prominent than the other eye, then the main thing is to find out about the nature of the facial asymmetry. So if there is a bony asymmetry, then that is going to be you probably will be better off by, this is my opinion, by doing a CT scan, because that's going to give you a bit more detailed assessment of the facial bone, and it will give you an idea as to whether the proptosis which you're seeing in the clinic is actual proptosis, or is it because one side of the face is slightly sunk in, and as a result, the other side is appearing prominent. And the same, I think, issue is with what we call a pseudoproptosis. So you may have, a case of a myope where one globe is bigger than the other globe, and you might find that you're being referred this patient by one of your colleagues saying that this patient actually has proptosis. So my request to the juniors is that also measure the size of the globe before you decide that this is actually a case of proptosis, and ensure that you would have done a simple biometry and a scan whereby what is the size of the globe. And a lot of these cases will not need any further investigation, any costly blood tests or chest X or MRIs and CT scans. If you can just ensure that we have diagnosed that this is a case of pseudoproptosis because of the elongation of the globe.
And also, sir, I would like to, one thing is, if globe, if there is a pseudoproptosis, then retropulsation is helpful. If there is a on the pressure on the globe. If the globe is retracting the orbit, it indicates that there is no mass lesion. It could be that there is the due to the increase the length of the eyeball.
Absolutely. But you know, that is also an acquired skill. Quite a few of the juniors may not be able to understand what exactly is the, you know, pressure they have to apply for get the, you know, that feel. It will come with practice. Of course, we all have learned that way, hard way.
Thank you, sir.
Yeah, so you're rightly mentioned. In all setups, at least in all eye setups, the A-scan is easily available. So we can have some amount of clues with A-scan. So in Excel, and even we can scan little bit the behind the eyeball also. If you are very tuned with your A-scan, so you can do few points. So on that, you can. So in
I think
each
it's very
and every
important,
setup,
very
there is a
important
A-scan is
to
very
pass
useful.
on that message that, you know, we do not
Yeah.
need an expensive instrument like a Hertel's exothermometer to measure the proptosis. We have to actually teach our juniors. The juniors, actually, there are a lot of, you know, good YouTube videos as well from reputed sites like the, you know, American College or the Royal College. You can find that, you know, these people have explained how to use these kind of, you know, very simple instruments, you know, usual office instruments to, you know, do this kind of clinical examination. And that kind of brings us into the focus which Dr. Bhaskar has, you know, highlighted very excellently, very competently, that, you know, it is so important for us to understand the value of history taking. Because we ophthalmologists, sometimes we just, you know, go right to the slit lamp and, you know, just put them on the slit lamp and have a look in the eye. But it's so important to understand the nature of this kind of, you know, diseases, the progression, the amount of pain, the type of pain, you know, the clinical examination as to whether the globe is being pushed downwards and inwards or downwards and outwards. You know, all these little informations will give you an idea as to what you are dealing with.
Another issues are burning issues is that is in bilateral proptosis, or it may be a unilateral proptosis with thyroid orthognopathy. Because most of the physicians are generally label it on the basis of T3, T4, and TSS. But thyroid ophthalmology is a basically, I want to share with our juniors and residents. So it is a basically mostly is a clinical, not on the basis of parameters of thyroid. Suppose one patient that 33% may be a euthyroid stage, 33 may be a hypothyroid, 33 only the hyperthyroid. So our earlier conception was that it is a hyperthyroidism, is a proptosis, but it may be in transit phase. It may started from hypothyroid, or it may goes to hyperthyroid. On the transit, there may be a euthyroid stage. So there is a euthyroid, and most of the physicians, those are little on a more than 2 decades ahead, or they pass out more than 3 decades, 4 decades. They don't don't want to accept it. So it may happen. So they are generally always telling, so no, you don't have any thyroid problem. That's another big issue with our oculoplastic surgeons now. So I want to share, so there's some parameters like anti-TPO, thyroid globulin antibodies, and pre-TTT4. If a same patient TSS, T3, T4 normal may be a normal for a long period, but if you look at anti-TPO, there might be some changes. There is an era of IgG4 in investigation. So many points. So I want to share with our residents their experience about those things. Some are not mentioned in the book. Yes.
I think, sir, let us ask our residents. I can see Dr.
Yes,
Rajiv Kumar
that's
here.
right. Some residents are
yeah, Kangsha, you know, so many residents.
Do
you have any?
residents?
I will encourage their participation.
Yes.
Can we have a word from Dr. Aparna also? She has not.
Yes.
Yeah.
Regarding the thyroid test, sir was very rightly, he has pointed out, whenever a case of thyroid ophthalmopathy with clinical symptoms come, we first And if it's a fresh case, it has not been evaluated anywhere else, we should always go in for free T3, T4, and TSH along with thyroid-related antibodies also. So because the ophthalmologist might be the first one who discovers that this patient actually has a thyroid condition underlying, though these patients might be subclinical also. So that is one point I wanted to highlight.
Thank you, Dr. Aparna. Yes, nicely mentioned. So there is a one, maybe in hypothyroid, it may be in euthyroid, or it may be in hyperthyroid, or there is another term is subclinical. There may be a subclinical interest, and there is that's why the intraocular pressure assessment in thyroid. So there is a raise sometimes. We may misdiagnose is maybe a early POAG or something. So there is some points. So we can go for a gonioscopy, especially in cases of CCF. If we do a gonioscopy, we may find it something in the Slam's canal and the blood. So those are the COS signs. So I just request our residents to take active part, and you can ask, we can try to, if possible, we can try to give you some inputs, and please ask what your queries.
So may I ask a question?
Yes.
So why active phase of thyroid disease lasts for 1 to 3 years, as per mentioned in the books, and it exacerbated by use of radioiodine and the treatment part?
That not mentioned in all the time every 2 to 3 years. But most of the time that happens, generally that patients with that there is other symptoms, so that physicians taken care. So ultimately is in that phase. And if we treat, this is a tendency is like if we treat the thyroid ophthalmopathy in active phase also, there is a chances to regress. Whatever the mass with a proper control, but it should be a proper control, metabolic control. The thyroid may associate with diabetes, may associate with the hypertension, may associate with the metabolic disorder, maybe is a systemic disease. Not only eye, like in flood. Thyroid is like there is a more rain in the air, in the hail. There's a more, that effect is in the valley. It's like that. We can control in the hail also. Not only that we cannot only concentrate on ours. So there is a teamwork, and sometimes we can protect cornea. Sometimes there may be a pain. There may be pain is due to the dryness only. Then in all thyroid ophthalmology there is, and is the book is says probably this is the cause, and there is a spontaneous some amount of adjustment of our body. That's the reason there's not too much of active phase. But this also depends. It's not true in all that time. There is some depends on the parameters. What are the parameters? What are the level of PT-TT4? What are the thyroglobulin antibodies? What are the anti-TPO? All factors. It's a multifactorial, not only a single factor.
Thank you.
Yes. Any other questions? Basically, this is those are symposiums or CMEs are basically for young. Basically the residents, senior residents, and the things. You can, what you are facing, you can highlight all those points, then we can try, and there is a from recent you can tell few points, recent advances. I just invite all our residents to take part actively.
Any queries? I think we have from any residents. Dr. Akansa is there.
If you feel a day-to-day practice, just ask the question. If you feel any problem.
So I had a question.
Yeah.
So in pediatric cases with proptosis, is the evaluation protocol followed same as we do for adults, or there's anything else in pediatric patients?
Yes, almost there, but pediatric is nowadays there's a lots of points. Pediatric age is less than 18 years. So it's preschool, school going, and I have some patient, I have in video documentation also, 3 years, 4-year-old girls is laughing during once that anesthesiologists inject the drugs before anesthesia, laughing.
Okay.
And
Okay.
after that is just a early recovery also, she just, if your mom also says, so your tongue, she is cooperating. Next day,
Okay.
she's climbed up to the bed. So
Okay.
on some pediatric patients are so intelligent, so cooperative. There's a no
Yes.
such, then they are
Problem with.
more cooperative than any other adult. So it depends on education system of that kid, the environment factor, and the tolerance capacity of the kid, and intelligence, all. So pediatric is a vague term. So basically we are thinking all, but there is some rule in pediatric is not possible for you to a reflection like a authorep, you have to do some things. You can look, is not possible. Generally, sometimes we need a ZA. For proper examination, we may need a ZA. So those are the points in protocol, like in investigation, like in MRI, they may move. It's very, very difficult, especially some investigation. Ultrasound in cooperative kit you can do, but MRI is impossible in most of the time. So need a ZA. So those are
Okay,
the
sir.
some points. It's very good
Right, sir.
question. Yes.
Thank you.
Very important thing is you always should take the proper history because sometimes the baby is uncooperative and come with the pain, proptosis, swelling, sudden. Then you should after proper history, you all directly go for the any investigation without proper workup, because under sedation or you can examine, but patient is most of the time uncooperative, as sir says. But if you think there is a proptosis, pain, then you go for other investigation like MRI, CT scan under the GA. Depend upon the condition of the eye and depend on the proptosis and history.
One more thing I would like to add to the juniors is that, liaise with your local radiologists, talk to them, and give them the history. Never send a patient just for a scan. You have to understand why you're doing this scan. Basically, in a case of proptosis, we're doing this scan to find out about A, the nature of the problem, and B, how we can do an orbitotomy to get some tissue sample, either for an incisional biopsy or an excisional biopsy. So it's very important that we understand this issue and we talk to the radiologist in concern. Also get into the habit of, going to your radiology clinic and looking into previous plates, MRI plates, CT scan plates, so that you also can have some working knowledge as to how to read a scan. Do not always rely on the radiologist's version. With all due respect to our radiologists, they have a very onerous, very difficult task. They have to be an expert from, the tip of the hair to the tip of the toes. So, it's not easy for them. So sometimes they're not that much experienced in orbital surgery, orbital lesions. So they may give you a report which may not always be what happens in real life. We all know that we have seen those kind of things happening. So don't go by the report. You're not treating the scan, you're actually treating the patient. So you are actually, you have done the best for the patient by doing the clinical examination. You've taken the proper history. And when you're going for the scan, ensure that you are getting the best possible scan for this patient.
I would like one more point, sir, over here. So after your clinical examination of either a pediatric patient or an adult patient is done, do not forget to do the blood workup. Many a times in pediatric cases, they are sick children and we need to rule out leukemias, which is quite common. And for that, we need to do the peripheral blood smear too. So once you have ruled out everything, only then plan for a biopsy, or otherwise you will be burning your fingers if it's a leukemia and you directly jump into taking a sample. So the metastatic workup and the blood workups has to be done, and then only you should follow up and the radiological examination, and then only you should go for a biopsy.
Yeah, Doctor. Yeah, Aparna, you are mentioning very nice point. So blood parameters, that's routine some tests. Like during the examination also, we can look at hemoglobin, the health of the soil, the hair color, all those are in the book is mentioned. So our aim is to capture the investigation as much as possible. Our clinical aim should be our clinical diagnosis near to that actual diagnosis. That's the aim. Our clinical assumption and the diagnosis, it should be nearer as much as possible. Then we can capture the investigation. So routine blood is a very mandatory test. Very important test. So sometimes there may be some issues. Even there is in patients with pediatric age group, there's a thyroid. So we can look some parameters and clinically we can assess. And one important thing is that as our structure is very small, other departments like radiologists, pathologists, they are not too much tuned because maximum number of cases are from abdomen, maximum number of cases are from chest, maximum number of cases are other parts. So that's the reason that if you look the protocol of the radiologist, of pathologists, etc., the diseases, if we are go back to our MBBS life, so we are not so much tuned on those diseases. So that's our take-home information. So that all the residents should be, we can consult we can just apply our clinical knowledge as much as possible in that evaluation. Dr. Gyan, please, if you want to say something again.
Sir?
You want to say, highlight some points?
Dr. Kansa is there. I think she wants to ask something.
Yes, I wanted to ask one thing.
Please go ahead.
There are two entities like in orbital cellulitis and non-inflammatory orbital idiopathic inflammatory orbital disease. Both the conditions, it usually mimics both of them. The clinical features are almost the same, but the diagnosis part after orbital cellulitis needs immediate management in the form of intravenous therapy or intravenous antibiotics. But in idiopathic disease, it is a usual diagnosis of exclusion. So should we wait for the exclusion part, or we should start antibiotics immediately on the basis that it could be orbital cellulitis?
Orbital cellulitis, basically, it is a diagnosis, clinical diagnosis. If you look carefully, most of the time, all signs of that will be there, which is in idiopathic, especially in pediatric, it is very less. And you can go to the history, that is in rapid, progression is rapid, pain and etc. are more, rubor, there's redness, temperature, other sign. If you look on the toxemia, maybe with the cellulitis. If it is localized, it may be different, but if it is a diffuse type of in orbital cellulitis, there is a sign of toxemia, there is a tachycardia, all signs are there, which may not be possible in there. So now there is a nice thing that we can say, we can immediately do a ultrasound handheld, or we can go for a even MRI or CT scan. Then we can easily you can differentiate. So then we can start. There is no such harm to start an antibiotic if the patient cannot afford or patient may not return to your clinic. If there is a doubt, in such cases you can start. But ideally, you should find it out what is the disease is, because it's an emergency.
Okay, sir. Thanks.
Sir, good evening, sir. I had one doubt regarding the palpation technique for pulsations. So is pulsation a finding seen on palpation or by observation? Hello? Sir, am I audible?
Yes, audible.
Yes, you're audible.
Audible. Pulsation.
I think Dr. Gyan Professor Gyan, can you please comment or
What is the question? Please repeat.
what she's telling is pulsation. Is it is it on inspection or is it a palpation? That's what I think. Is that the question, right?
Yes, sir. Because I have seen at least 3 different ways in which pulsation has been seen, either by using 3 fingers or the palm of the hand, or by just asking the patient to look forward or bend down and then look for any movement of pulsations. So what do we follow, sir?
Basically, you can follow all this. If all these things, clinical examination, if you think it's if there is a there is a history, the patient is having, there is a change in the bulging the eyeball, change the posture, or according to the duration, then you ask the patient either the Valsalva maneuver, or in the you can ask the patient to bend down the head and count up to the 50 or 60. Then you see, but before going to the any test, always do your primary recording, a primary measurement of the proptosis. After that, you go for this test. Either you can ask the Valsalva maneuver, or ask the patient to bend down and count up to 50. Then you assess your amount of the proptosis. Okay.
Okay, sir.
So
I
just
think for very minor pulsations, I think, if I am right, the Jentada, I think will this thing help me
Yeah.
out. I think when
Yes.
you use, for very, when you have a gross pulsation, there's no problem in detecting that. But when you have a very fine and this thing, a subtle this thing, people use this the Myers of the seen in the the Goldman's applanation tonometer. Okay, put it on the cornea if it is clear, and then you can. This is also another way of detecting very, very, very fine pulsations.
Yes, very good. Very good. And one is that you are asking that question is a observation or it is a pulsation. So both are correct. In MCQ, like in answer, it is both are correct. In some cases, it is there is a observation also. In CCF, there is a auscultation. So by bail of the stethoscope, you can. Or as Dr. Chenchui mentioned, that you can just examine the patient in a CCF. If you are asking the patient to look up, there may be raise of IOP 2 to 3. That's one point. And the Myers, you can observe the Myers. There is some sense on the Myers. Those are the points. If you look carefully, so both are correct. By observation also you can. And in palpation, in a small, there is if the lesion is small, like a CCF is small, so only the palpation. But if the CCF is big, so even you can see the pulsation. It's a type 1 CCF, grade 1 CCF. So direct CCF, you can see the pulsation. But in a indirect CCF is not possible. Even with the bail of the stethoscope also sometimes not possible. So in such scenario, it is totally different. But both the things you can apply. It is a gross observation. If it is a very, very small and more finer, definitely auscultation. Both are correct.
Thank you, sir.
Any concluding remarks, sir, from either Professor Gyan or Jentada? Any last take-home messages?
Is going to question anybody else left?
Yes.
Otherwise,
sir, I always stress on proper history. If all the for all the resident, it is try to take a proper history. According to history, your planning is for examination followed by the investigation. If they don't take proper history, then unnecessary बहुत सारे thing order होंगे investigation के लिए. So always check the proper history.
Yeah.
Excellent.
Absolutely. One does not have to only confine yourself to the eye. You have to examine the entire body in totality.
Yes.
Yes, sir. Yes, sir. Yes, sir. So I just want to say one point. Our clinical that should be always better. Human intelligence always better than artificial intelligence, machinery intelligence, because machines are depends on our brain. Though that machine can work more, MRI can faster, but the technician should know at what plan, what are the cuts, etc. That theoretically it is that machine should, if that machine we can command, the command is in our hand, doctor's hands, and we can go very easily. But if you are under the command of the machine, then it will be that machine may mislead us. There's so many issues. Mobile is that high tech is very good, but if you don't want to, if you misuse it, so it may spoil our life. That's the take home message.
Yes, sir. I think
one simple query. What exophthalmometer a general ophthalmologist should have?
Hotel, sir. At least hotel should be in the hand, sir.
What about, you're talking about leaders now?
Hotel, sir.
Hotels.
Sir, hotels is very little costly, and that there is now Indian companies are there, and in institute it is easy, but for a practice or a small setup, little difficult, sir, little. So, and it is not easily available in the market also. Is it, Gyan, doctor? It is not easily available.
So, what do you suggest for the resident PGs and people like us who are not into
individual setups?
Individual setup, small setup, or in the hand of residents, that loads two good quality plastic ruler. That three things should be there in examination. It is a very simple rare, and it should be, and we can use it. And gonioscopy you should know, and we should know what are the Myers position, then IOP calculation, everything. If you know, then almost we can compare. And Professor Bhaskar is from big institute. Tashin Sui also big institute. So okay, that's issues. But even in that is my practical experience. I was in a tertiary care hospital. There is only one hotels out of the three oculoplastic surgeons. So sometimes there is if there is in one OPD, the other OPD is lacking. That if the other, we are not in the same OPD. So that's some issues. Okay. So better that it should be some plastic rulers, good quality, and what one looks.
Yeah, because that is very important for documentation purpose.
Yes, sir. Yes, sir. And sir, for documentation, proper photography. Proper photography for each and every patient is very important. Documentation, pre, post, and CT scan, all others. But patient may lose the CT scan, or for him it may not be important, but for us it is a asset. Documentation is very important.
Okay then, sir. I think we'll call it a day. Thank you so much. I think it is a wonderful evening. I think we had a very great discussion on an important topic like proptosis, which we all used to. I mean, we cannot run away from every day. I mean, if you are a practicing ophthalmologist, I mean, it is so common. So it has been a very, very nice discussion. So on behalf of the ARC, Eizoc, I will first of all like to thank Professor Gyan Bhaskar for giving a very, very detailed discussion, which I think will help our residents and common ophthalmologists alike. And this not only help them, but also enlighten the general ophthalmologists, people who are not into oculoplasty like us. Thank you so much, sir, for your time and giving us this wonderful presentation.
Thank you, sir.
Next, I'd like to thank our own Jayantada, who has very, very masterfully moderated today's session with his insightful inputs and very, very helpful inputs, and for kicking up a very, very nice and lively discussion. Thank you so much, Jayanta sir. Next, I'd like to thank our panelists, Dr. Rajesh Chaudhary, sir, and Dr. Aparna Dwivedi. Thank you so much for your inputs and helping us, clarify some of our doubts and some of the residents' doubts, and helping us understand this topic a little more better. I'd like to thank, our residents, Dr. Akansasa, Dr. Rutusa, Dr. Swanubhuti, and Dr. A few more were there. It is basically for you and for the common ophthalmologists that we are doing these ARC webinars that are being targeted. I'm sure you'll be benefited, and as will be others. And thank you for your active participation. Again, I'd like to thank our President, sir, our own Pranav Ranjan, sir, and President-elect, sir, Zenta Barua, sir, our Secretary, Soras Da, I think he's not there today, our Chairman, Scientific Committee, for wholly supporting our ARC programs all throughout, and then standing right behind us and giving all the necessary strength to carry forward. I also want to thank the audiences, wherever you are, in whichever channels you are watching, for giving us, making this program a big success. And last but not the least, I want to thank Eizoc for their technical support. Mr. Rahul is there, and all the other distinct from Eizoc for serially, on a serial basis, actually, they have been supporting us with the technical part of this webinar. Thank you all so much, and have a wonderful evening.
Thank you.
Thank you, sir.
Good
Good
night.
night.
Good night.
Thank you, sir.
And the recorded version will be put in the YouTube, so anybody later on also can listen to the webinar, and will be distributed in all groups also.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Good night, sir. Thank you, sir.
Okay.
Thank you, Jayanta, sir.
Thank you very much.
Good night. Good night. Good night.
And thank you, Professor Mathi, for taking so much of interest. Thank you so much. We are looking forward to another one next month.
Next one, sir, it'll be there, sir.
Okay.
Thank you, sir. Good night.
Thank you, sir. Pranav, sir. Thank you, sir.
Thank you, sir.
Pranam, sir. Pranam.
Bye. Good night, sir.
Good night.
Good
Good
night,
night.
sir.
Janto Barua, sir. Bye-bye. Bye-bye.
Bye, sir.
Good night. Good night, sir.
Rahul, thank you so much, Rahul. So he's gone to sleep, I suppose.
Okay, sir. Good night, sir.
Okay,
Good night.
Good night, sir. Good night, sir. Good night, sir.